Hey, everybody, it's Dr. Jamie. Thank you for listening to the Fit and Fabulous podcast. And I really want to give a huge shout out to today's sponsor, which is Secco Wine Club. You guys have seen me posting about it. You've seen my stories. I love Secco wine. It's a low carb wine, and it's the low carb wine that I'm going to be serving around the holidays here at my house for Thanksgiving and Christmas. And you know what? Palo 61 is my favorite wine. It comes in red, it comes in white, it even comes in a rosé. And usually I'm not a fan of those types of wines because they're real sweet. You guys, this is low in sugar and it's super safe for you. And I love it. And I know your family's going to love it too. I do have a code that gets you free shipping on 3 bottles or more at SeccoWineClub.com. That code is Dr. Fit. That's DRFIT at SeccoWineClub.com. You guys, this is glucose monitor approved, and I've checked it with my own CGMs. It's low in sugar and it's low in carbs, so it's completely safe for all the people that are keto and paleo out there and are staying that way through the holidays. This is old world organic, you guys. That means it's 100% Italian wine. There's no intervention, no chemicals, no additives, no sugars. It's just real wine. There's no membership that's needed to try Secco Wine Club. You can save big with a membership. You guys can order this anytime and get free shipping with my code. Thank you to Secco Wine Club, and thank you to all of you. Happy holidays. Welcome to the Fit and Fabulous podcast with Dr. Jamie Seaman. Hello, everybody. It's Dr. Jamie. Welcome to the Fit and Fabulous podcast. Thanks for listening today. You guys know how much I love and appreciate when you share our episodes, you download them, you like them, you leave comments, you share them with all your family and friends because you guys are truly helping us spread these messages around the globe. I cannot wait to introduce you to today's guest on the Fit and Fabulous podcast. She's a super badass mom, OBGYN, MFM. You guys, she does all the things. Okay. She's part of the Fit and Fabulous posse for sure. Dr. Clark Ganhart, she's a board certified OBGYN, like I told you, and she does maternal fetal medicine and obesity medicine. That's a little different than some of our colleagues. Okay. She's got some extra training in a lot of things. She's the president and CEO of Perinatal Specialists of Kansas City. She's known as the fasting doctor on social media. You can go right now over to her IG and find her. Dr. Clark Ganhart works with women that have high risk conditions in their pregnancy or maybe a baby that's high risk. She also has a preconception wellness clinic, which is designed to maximize health prior to pregnancy to reduce the risk of pregnancy complications. That's, of course, right in my wheelhouse, you guys. I talk about that all the time. She graduated with her undergraduate degree from Michigan State University. I won't hold it against her. I'm a Cornhusker. But she went on to earn her medical degree from Michigan State University College of Human Medicine. And then she furthered her training by doing OBGYN at Hurley Medical Center and then a fellowship in maternal fetal medicine at MedStar Washington Hospital and MedStar Georgetown University Hospital. She's a huge advocate for lifestyle and wellness interventions, particularly intermittent fasting. And we're going to talk all about that, as well as low carb diets. And she's personally lost over 50 pounds with these methods, which means you guys, she doesn't just talk the talk, she walks the walk. Dr. Clark Ganhart, welcome to the Fit and Fabulous podcast.
Thank you so much. Thank you for having me. I'm thrilled to be here.
Well, everybody heard all your qualifications and you're absolutely qualified to be speaking on these topics, but tell me a little more about your personal journey, because I just think as medical providers, yeah, we all learn, we go through the same lectures and things like that, but we all have some personal story that changes the way we practice medicine. And I think that's true for you. So tell us more about that.
Yeah, so I think like many people, we're busy. We always have something to do. We always have an obligation. We never have time or never take the time, right, to prioritize ourselves. So I think, just with residency and medical school and all of that, like I got really, I would say into a bad habit where it was like, I had all these things to do, and then something for me would always be last. And so when that happens, that can manifest itself in a lot of different ways. But for me, it manifests itself in just always chronically carrying more weight than I should. And I would go through periods where I would lose weight or, work out more or kind of pay attention to more of what I was eating. But it always seemed like something would get back and, get in the way and I would slip kind of into my old habits. So In 2017, I saw Dr. Jason Fung's book, The Obesity Code. And so I was like, I tried everything else, eat less, move more, all the things. But fasting wasn't something that I had actually like tried or intentionally tried. So I started that and actually noted like really good results. So like at the time that I had my second son, Christian, I have three boys. At the time that I had my second son, I was the heaviest I'd ever been. I was like 264 pounds. So I was like, if I kept going in that direction, it just was going to be much harder for me to like, I think, reverse things. And so with intermittent fasting, I like saw myself losing weight, but most importantly, I was feeling better. I was more energetic. And then I think whenever you start to see progress, you want to learn more. And so ended up reading a book by Dr. Kate Shanahan called Deep Nutrition.
Amazing book.
I love that book. It's such a great book. And started incorporating a lot of her suggestions as well. And was able to lose like pretty much most of the weight that I wanted to and keep it off. So I just think, having that personal experience, that's then what kind of led me to look at obesity medicine because that's not, what I went to residency or
Right.
fellowship for. But I thought, like if this could work for me, I'm sure it could work for other people. And so, especially being, OBGYN and high risk, we see so many of the pregnancy complications that are the result of medical conditions due to
Right.
lifestyle.
Metabolic syndrome, obesity. Yeah.
All of that. And I think people have gotten so used to seeing these medical conditions that we forget like if we actually improve these things prior to pregnancy, like your pregnancy would be a lower risk pregnancy.
Mhm.
And so I think just with my own experiences, it kind of, led me to want to get more into this space and show people really that there are lots of physicians that believe in preventative medicine.
So do you think that incorporating the intermittent fasting was you'd obviously tried a lot of things. Why did you find success with it? Why was it different than just eat less, move more? Because
I
that, I mean, because intermittent fast, I mean, some people will argue that intermittent fasting is just eating less.
Eat less. Yes, yes. I've heard that argument too. I will say with intermittent fasting, I can definitely say I don't eat less. It's my meal timing. I would say my food quality is better too,
Yeah.
though. So intermittent fasting, if you and I'm oversimplifying it, but many of us have insulin resistance. So when we're trying to lose weight, insulin resistance, or if you want to, the technical term, hyperinsulinemia, actually having too much insulin, can impede weight loss. And so for me, and what a lot of the studies will show is that when you actually stop eating as frequently, also if you're a night eater, that was a big problem for me too, especially if I was like on night float or night rotation or call in the hospital. You're up, and so now you're snacking and eating and all of these
Yeah.
things.
If I have
Um,
a 3 a.m. delivery, it throws off my satiety for like 24 to 48 hours.
yeah, yeah, because I mean, and I don't think we pay attention enough to that. Like, it's not hokey, you know what I mean? Like, it's true. Our bodies really are aligned with the sun, if we'll let it. So the with incorporating those things, honestly, my insulin levels came down, and so too much insulin, right, can cause inflammation. You retain fat. I mean, all of these different things. And I really think it was just breaking up that cycle of insulin resistance and then also learning to eat when I was truly hungry and realizing that if I'm not hungry, I don't have to just eat because it's time. And so I really think getting reacquainted with actually what hunger was
Right.
helped me tremendously.
Yeah. I think women in particular are very emotionally attached to the dopamine response from food, carbs,
Mhm.
foods that contain sugar, flours. They're very highly palatable. I myself was a total carb addict growing up. and use that as an emotional crutch sometimes, especially as I became a physician and I was just like you were saying, like working long hours and I'm a mom. And I started to come up with like, I deserve this. I just did 4 surgeries. Like I can have this Rice Krispie bar. And when you look at society as a whole, from even when babies are little, right? They turn 1 and we're like, here's this cake on their first birthday, like smash it and let's celebrate. And not that we can't have those things for celebrations, but let's be real. Every hospital, every clinical break room, like there's treats there on the daily.
Yes. Like everywhere. You can find them at the nursing station, you can find stuff everywhere. And I mean, I think too, we have to realize that it's okay to pass, on a meal. So I use my kids as a perfect example. So like, or you can honestly probably look at anyone's kids. Before you actually introduce this concept to kids, that it's time to eat, especially during summer months, like you might have kids who get up and they'll go play outside and they won't come back and tell you they're hungry for a long time, but then as parents we're like, oh, are you hungry yet, are you hungry yet? And it's like, no, no,
Yeah,
no,
time for
they,
breakfast.
yes, time for breakfast. Like, no, 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 they will come find you when they're hungry. Like they will find you when they want to eat. But it's just like, from an early age, we're trying to tell people like you need to eat at these specific times, or here it is, it's time for your snack, or here it is. And it's like, we really need to let hunger kind of be the cue, not that it's time or I'm trying to relax, I'm going to relax with this whatever.
Mhm.
We if we can get back to using food more for its purpose, right? I mean, that in itself is going to help us reverse a lot of syndromes.
Yeah. I mean, if you're eating 40% or more of your calories from carbohydrates, you're going to have a tough time with satiety trying to do something like intermittent fasting. And so
Mhm.
I think that, hand in hand, the nutrient quality of the food almost has to be incorporated with this type of thing. Um, I just think it does because the animal fats and the proteins and things are a lot of times what provide that long term satiety for people.
Well, and also too, that's the same thing kind of that I'll tell people. It's that like if yeah, I mean, pick what you want to choose first. So like I think whenever you're making a huge lifestyle change or overhaul, sometimes I do think it's easier to like focus and break it up stepwise so that you're not just like in shock. But like eventually you should address all the things. And so if you are kind of like I can do intermittent fasting and not pay attention to what you eat, you're really kind of just treading water. So you may not gain weight, but you may not make the progress that you want. And aside from weight, right, like autophagy, like healing, those benefits. And it's like, if you have a garage, right, we'll use the garage as an example. If you have a garage and it's junky, and every once in a while you'll take out one box, but you replace it with two more boxes of junk, you're never going to have an organized space, right? So, like, it might function, but it's not functioning optimally. And so that's what we have to look at with nutrition. Like, intermittent fasting is great, but your nutrition is day in, day out what your cells use as input to how it should function. And so we have to pay attention to what we eat as well.
Yeah, I had a reproductive endocrinologist, Dr. Kiltz, on the podcast recently, and he likes to call it intermittent feasting instead of intermittent fasting because he feels like it puts the emphasis on what you're feasting on and not that because just like keto, it's like all of a sudden fasting's like getting a bad rap, like
Mhm.
people think it's like some evil thing. So if how did you start? Like, how does somebody choose their window? What window do they choose? Like, how does somebody start?
So one, I think what I have my patients do is that you really need to look at your schedule because what I'll see a lot of people do is like they'll hear about fast from or I'm sorry have an eating window from 12 p.m. to 8 or 8 p.m. But they know they have a work schedule or a life schedule where that's not going to work. And so I really think you have to first thing I always ask people is like, tell me, when do you think you can stop eating by? Or tell me when you think how long you could go in the day realistically and not have your first meal. And so people will pick all sorts of times. And then we're like, okay, well, let's start with that time. And then, I want you to try to get in, I want your eating window. Let's start with the 8 hour eating window. So if you tell me you think you can wait and start to eat at this time, then count 8 hours, and that's when you're going to close it.
Mhm.
And then they just get used to doing that. And once they're used to doing that, we'll then analyze the window more. And we're like, okay, you're not eating, until 2 o'clock, but now you're eating all the way until 10 p.m. at night. Let's talk about all the reasons why we probably shouldn't eat until 10 p.m. at night. And kind of go from there. If you've never fasted before, or if you are still in like a very processed foods type diet, then I tell people just to start from 8 p.m. to 8 a.m. and just get used to that concept, and then tighten the window as you get more familiar with fasting. Or if you're not ready to go longer, do 8 p.m. to 8 a.m., but then focus on reducing carbohydrates.
Mm-hmm. Yeah.
So,
I just love how customizable it really is for people, and it's completely free. It's so inconvenient for me to have to eat more than 2 to 3 meals a day because I
same.
live a crazy schedule, and I am not really hungry when I wake up. And there is kind of a point in the day, it's usually about 11 o'clock for me, when I naturally start to really get hungry. But when I'm in clinic and I'm in and out and I'm seeing patients, sometimes I'm eating through my lunch hour and whatnot. And so I love that even on a day-to-day schedule, I can kind of figure it out. You brought up an interesting concept though, of like, maybe it's not ideal eating before bedtime. There is some, debate about intermittent fasting versus time restricted feeding, which for people listening is essentially when we were talking about circadian rhythm, is like, the $1 million question: is there a time of the day that really physiologically makes the most sense to have our eating window? How do you feel about that? Or how does that work for people?
So I think there probably is a time of day that makes the most sense. But I will say, and it's not to make an excuse, but I will say that depending on what your work schedule is, you know what I mean? Like ideally, I would always love to stop eating um, by the time the sun goes down. But I'm in Kansas, and during the winter months, I mean, it could be like 4:30 or 5 o'clock, and I'm not even done with clinic yet. Do you know what I mean? And
Yeah.
so then what's going to happen is if I stick to that all the time, I'm going to end up fasting probably 36 to 48 hours, like several times a week, because I can't accommodate that schedule.
Mhm.
So that's why I tell people, I use like the 8 p.m. kind of as a baseline target, because I think the majority of people, at least that I've seen or work with, are eating much later than that.
Yeah.
And then, to try to gradually bring that in. But I mean, there are studies that have shown that, I know people say it doesn't matter what time of day you eat, but after the sun goes down, that same meal that during daylight hours will elicit a greater insulin response after dark. And so, I'm not saying you always have to eat before dark, but you should at least be mindful of how late that you're eating.
Yeah. There's an awesome book called Circadian Code that talks about kind of when our, satiety hormones and things are. I've always felt in my heart of hearts that it was better to eat early in the day, right? Because then you're active and you like burn it off. And I work out in the morning. So I always was like, oh, I really feel like I need to eat after I work out, but I usually don't get hungry till like 11. So it was always this game I played trying to find my perfect eating window.
Mhm.
And I do know, some people do this concept called OMAD, or 1 meal a day, which is essentially like 23 hours of fasting and 1 hour of eating. And I know that that does not work for me, because by the time I get home from work to eat that 1 meal, and I'm probably not going to overconsume, but it just mentally, I am like ravenous, and it's
Yeah.
hard for me to listen to my normal satiety signals. So for me, 2 meals typically tends to work better for me in kind of a 6 to 8 hour window, and it just works wonderfully. But yeah, I'm with you. We do tend to have a little bit better insulin sensitivity in the evenings, which it makes sense to have, a meal then. But if you want I think it's hard as a society too, because I have kids and it would be weird for me to sit down at the family table and not eat dinner with my kids.
Right.
Yeah, but just pick a window and stick to it, be consistent. I think that's really good advice. So let's talk about, you are an MFM, high risk doctor, but you also work with patients who want to get pregnant.
Mhm.
Obviously, you highlighted that we have a major metabolic problem, obesity problem, and so it's not hard to find patients that are really, struggling. Talk about how this can help patients, with fertility and with getting pregnant.
Yes. So when when we're planning a pregnancy, right, it makes sense that you want to optimize your health prior to pregnancy. So traditionally people will have a preconception consult with, either OBGYN or high risk OB, depending on what their condition is. And in the preconception consult, a lot of times just in general, people will go through and say, well, you have this medical condition, so you should switch these meds to this before pregnancy and et
Mhm.
cetera. What I like to do is, in addition to making sure their medications are safe for pregnancy, we talk about, well, how can we improve the medical condition as a whole? So, for instance, people may struggle with like polycystic ovarian syndrome. And, a misconception with PCOS that I think a lot of people have is they assume if someone has PCOS that they're overweight. And that's not necessarily the case. And I think, that's a myth, unfortunately, that's still out there. But we'll look at all sorts of different medical conditions. The common core in metabolic syndrome, or if you don't have full metabolic syndrome, still say you have, hypertension or obesity. A lot of these core conditions has hyperinsulinemia as the core, or as a component, right,
Yeah.
of the problem. And so that's what we look at and basically start intermittent fasting, but also look at nutrition, seeing how we can improve, um, lower, carbohydrates, processed foods, but then also integrate physical activity, preferentially resistance training. But, I just start with people wherever they are, but kind of looking at all of those things because to have a healthy pregnancy, we want nutrition, but you also should stay physically active during pregnancy, which I don't think enough people talk about,
Mhm.
as well. And so it's trying to get people to make these lifestyle changes that can improve their fertility. If for some reason your infertility is not improved, and you end up needing, IVF or assisted reproductive technologies, still the healthier you are before going through that process is still going to increase the chances that it is successful and that you have a healthy pregnancy. So I think that sometimes people have kind of this all or none goal. Like if I don't reach this state of health before pregnancy, then it's all for nothing. And that's not true. Any lifestyle change you can make prior to pregnancy, whether you've reached your goal, whatever that is still going to help in your journey.
Okay, since you're a high risk obstetrician, essentially, can we dive in a little bit to what the risks of hyperinsulinemia, hyperglycemia, metabolic disease are in pregnancy?
Yes. So, especially with hyperinsulinemia, so let's look at just all the conditions that are associated with that. So, a lot of times, if we're looking at the full metabolic syndrome, right, in terms of having like hypertension, so hypertension, high blood pressure increases the risk for preeclampsia, which is high blood pressure when you're pregnant. States of hyperinsulinemia in general will increase that risk, whether you have the full syndrome or not.
Which
So
nobody ever taught me in my training, by the way.
yeah, and so
I
it's
had to
and
dive
I
into the
mean,
studies myself.
yes, well, and the thing is and I'm not saying that I fully have unlocked all the keys to preeclampsia because it is a very complex, disease at
Mhm.
a molecular level, but we do know that there is a component of these kind of diseases of lifestyle that make you at increased risk for preeclampsia. So
Mhm.
one would assume if we help to reduce that, and if hyperinsulinemia is at the core of that, right, then that should reduce the risk. Preeclampsia, for people who are not familiar with that, I mean, it's can be a pretty significant and severe disease for both mom and baby.
Mhm.
With once you develop preeclampsia, the only cure for that really is delivery, except you don't necessarily want to be delivered at 28 weeks because you have severe preeclampsia.
Right.
So that's just an example. If we're looking at high blood sugar, so having too high blood sugar levels in the blood is associated with birth defects. I don't think a lot of people realize that. And,
Yeah.
we're talking about pretty major, severe birth defects, like missing, part of the covering on the back of the spinal cord, like spina bifida. You can have other neural tube defects, is what we call
Anencephaly. Yeah.
anencephaly, where for people who may not be familiar with that, it's like actually missing the top of the
Mhm.
head, the cranium. So then the brain is exposed again, very severe condition, to complex heart defects. I mean, we've seen all sorts of things to babies not having kidneys, and you need kidneys to live. So I mean, there are all sorts of things that
Literally every system, congenital heart
every
disease. I have a slide that I gave at Keto Summit last year. It was like the kidneys, the neural tube, the heart, micro penis. I mean, there's
Mhm.
like a whole host of things that could be caused by hyperinsulinemia and hyperglycemia.
And miscarriage, I mean,
Miscarriage.
and
Yes.
stillbirth. So it's not, and so we don't say these things as like scare tactics. They're not scare tactics, but it's just like when you see someone and treat someone with that, and you're like, oh man, like I wish I could have met you like 2 years before. Do you know what I mean? Like
Yeah.
it's one of those things where um I know everyone wants to be pregnant like yesterday, but if you do have the time to improve your health before, again, I'm not saying that you have to, have reached whatever your goal was, but say you have a hemoglobin A1C of like 10, right? And for those who, I'm sure all your listeners are familiar with hemoglobin A1C, but for hemoglobin A1C, that's a marker of like how well the blood sugars have been controlled in like the last 3 months. So if you can take that percentage from a 10 to an 8 or an 8 to a 6, I mean, you have just dramatically increased the likelihood that you will have a successful pregnancy. You still may be diabetic, right? But through lifestyle, you can decrease your blood sugar. And so doing that has implications for healthy pregnancy.
Yeah, and I always tell people, do not judge a book by its cover because I thought I was healthy. And if you looked at a picture of me before I got pregnant with my second daughter, Sienna, my 1 hour glucose test in that pregnancy was 208. That is like most people wouldn't even let you go on to do a 3 hour at that point. They're like,
Mhm.
no, you have gestational diabetes. It's time to check your blood sugars. And I like praise God every day. My girls all appear to be very healthy, but there are studies that show this hyperglycemia, hyperinsulinemia can have what we call an epigenetic effect. Like her lifetime risk of obesity and diabetes is 50% higher just because that happened during my pregnancy. So it's a really big deal, not only for you and your health, but your baby's health, your grandbaby's health. I mean, we're talking about like generational impact of health outcomes when we talk about getting healthy prior to conception.
Right. And that's the thing too. You hit it right on the head. I think we get too focused on like what people appear. Do you know what I mean? Like appearance. And so, oh, you
Yeah.
look healthy. So surely you are healthy. And it's like, some people manifest their high insulin levels in obesity, but other people don't,
Mhm.
right? Other people have depression, anxiety. Other people, I mean, there's just so many
Yeah.
other things that go with it. And it's like when we look at the core, um, again, our nutrition really can help play a role in improving so many aspects of our health. But we get too focused on the scale or, well, as long as I can fit in that dress, I'm good. And like that's not necessarily the case.
Yeah. Okay, so one of the biggest questions that I get asked, because there's not a lot of players in this space, is what are your thoughts about carbohydrate recommendations in pregnancy? Maybe let's talk about gestational diabetic versus passes the test. And then do you think intermittent fasting is appropriate for pregnancy?
So I think we allow too many carbohydrates during pregnancy. So when people come to me for gestational diabetic counseling, I am stricter than ACOG. So I am.
Just
Yeah, yeah,
laughing. YouTube can see me. All
yes,
the other podcasters. I'm so
yes.
happy.
I'm stricter. I'm much stricter. So I don't necessarily make people go keto per se during pregnancy, but for instance, at lunch and dinner, the current recommendations are you can have up to as many 60 grams of carbohydrates, and I do tell people that that's probably just too much. And so I mean, I would say it's probably like moderate levels. So for instance, I'll tell people no more. And I'll explain my emphasis on no more than. So no more than 30 grams of carbs for breakfast, no more than 45 for lunch, no more than 45 for dinner, which is still not necessarily
That's
low
still
carb.
liberal. Yeah.
It's still liberal. But the reason I emphasize on the more portion is that I have so many people who think they have to hit the target.
Hmm.
And I'm like, so you don't have to hit the target. And if you are full, stop eating. Even if you've only had 15 grams of carbs for breakfast,
Hmm.
that's fine. So I give them those examples. And so when I look at people's diaries, they're actually more towards like 15 carbs for breakfast, more around 30 for lunch, and more around 30 for dinner,
Hmm.
because we have given them permission to stop eating when they're full.
Hmm.
And then I say, if you really are still hungry, then you need to go back and get like more satiated from protein, healthy fats, things like that. So um, I notice pretty good success with that. Like I said, it's still pretty liberal in terms of the guidelines, but I will say when you also give people permission to stop eating when they're full, you notice that people will naturally kind of, do you know what I mean? Kind
Yeah.
of
Yeah.
decompress more. So that's kind of where we're at. And if people want to go lower than that, I certainly don't discourage them.
Yeah.
That's kind of the happy medium I've found with taking people who are probably already eating like 300 and 350 grams of carbs a day. So essentially, I'm cutting that in half or below.
Yeah. I mean, basically cut them until the blood sugars are normal. Like
Mhm.
what we know improves outcomes for the mom and the baby is normal glycemia, because that creates, and the thing of it is even when you have normal glycemia, right? Maybe you have a patient that eats 60 carbs with every meal and her blood sugars are normal. Cool. At what cost of insulin are her blood sugars normal? And that's the question that the doctors are not thinking about. It's the question the patient doesn't herself understand.
Mhm.
But if your blood sugars are normal at the cost of a lot of insulin, your risks are still there.
Correct.
So, I can say just like cut the carbs until the blood sugars are normal. But I personally find most of my patients are somewhere between like 50 and 75. I've had a rare patient that does even have to go lower. I had one that was, I mean, literally, it was like just meat and veggies and just to keep her blood sugars normal. And that can happen in some situations. But I just think that we need to start having real, honest conversations about this. Our patients are heavier and more metabolically broken than ever before. And when people bring up, the risk of maternal mortality and morbidity in the United States and how it's so much worse in other countries, like we have to look at the patient population. We're in like the greatest country in the world where we have access to amazing specialists like yourself.
Right.
And we're
And we
still
still have
telling
poor
women
outcomes.
175 carbs is the low threshold. Like, do we
Right.
want to get better? Or, it's like, it's hard.
No, and I no, I totally agree. And that's why I was like, even And I agree. I mean, go down until the sugars are normal, but it's crazy too with even just starting with moderate carbohydrate restriction that you notice, do you know what I mean, improvements. Because we're eating just like I said, I think I saw something where the average American eats an excess of like 300 plus grams of carbs a day. Like you don't need that much. And so it's like trying to get people to cut down and do you know what I mean, and get used to that. The other important thing too, that I want to touch on are for all the women who pass that or who don't pass the 1 hour but pass the 3 hour.
Yeah. Yeah.
Those are the people, honestly, that I worry about more than the people who are under my care
Yeah.
when they don't pass the 3 hour. Because people think that, oh, I'm good, and they have a free for all. And that's where I see my 10-pound babies are people who pass that 1 hour
Mm-hmm.
because they're
Totally.
not thinking about it. And so it's like just to get people even to think about like how their food is impacting, but people hear the opposite. Oh, I passed my 1 hour so I can eat, or no, I end up passing my 3 hours so I can eat whatever I want. I'm like, no, 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 that 1 hour is telling you that you are not processing sugar correctly, that your insulin levels are too high. Do you know what I mean? Like
Yeah.
that's what
And
that
we
1 hour is
know
telling you.
we know from the hyperglycemia adverse outcome trial that it was a completely linear relationship,
Yep.
meaning we had to pick a cutoff somewhere to say this is the cutoff for gestational diabetes. But the people that were 1 point lower, 1 point higher, the people that passed them, 3 hour but failed the 1 hour, it is a completely linear relationship. So
Yep.
hyperinsulinemia, hyperglycemia, your risk is just a straight trajectory, linear relationship. So people just have got to like understand that. Okay, awesome. So let's talk about extended fasting. Do you do any extended fasting? Do you ever recommend it to your patients? Obviously not in pregnancy, but
Right, right. I do extended fasting, and I kind of just gauge my patients and see where they're at. So I always kind of take the approach with them, like if you're not hungry, you don't have to eat. I said at some point you will get hungry, and so I've had patients who will start off, they're kind of like already doing like an 18-hour, type fasting regularly. And then they push it to like 24, and on occasion they'll go 36. I have seen great results with and without extended fasting for patients that I've worked with. So I really kind of just gauge where people are at and the reasons that they want to try extended fasting.
mhm.
So I think it always goes back down like, well, why are you interested in the extended fast? If you're interested in it because you're like, oh, well, it was my birthday and, I had too much. And so now I got to get rid of everything that I did. And so I'm just going to do an extended fast. I kind of caution people against having that mentality where it's like, okay, if I eat poorly, then I'm going to extend it fast. It's going to fix it. I'm going to eat poorly again. And then I do an extended fast and I'm going to fix it. I don't like that kind of
Yeah,
concept.
it's that binge restrict behavior. And I've totally
Yes.
seen that with people.
Yep. So I don't like it used like that. I think if you it is your whatever. I mean, the holidays are coming up. So say it was Christmas, right? And you didn't eat like you wanted to around the holidays, then I think rather than doing an extended fast, you're best like just getting back on what your plan was, whatever, and going back, making sure to have whole foods again, getting back to your normal eating window, those things rather than saying, well, I'm going to make up with it for a 5-day fast. Now, that's my opinion again, because the binge restricting, I think that you can get into a slippery slope with that.
Well, I think it's like any form of like extreme dieting. We've seen these people like lose 50 pounds, gain 50 pounds, lose 50 pounds, even if it's 10 pounds, lose 10 pounds, gain 10 pounds. Like everybody seems to have that same kind of ebb and flow in life. And I've noticed that too. If I like really diet, like I dieted down for Mrs. America, gain the weight back, like, and we're just so obsessed with quick results that I think people are like, well, I'm just going to like fast for 60 hours at a time and that will get me there, quicker. And it is an amazing tool, but it can also be, abused in the same right. Just like we're talking about, it can create disordered eating patterns. But I just say the fastest way to get there is slowly.
Right. And extended fast, I'll do like a seasonal fast kind of,
Yeah.
just like a nice kind of autophagy clear out, and I just already know when I'm going to do that, and plan that. So I've seen people use extended fasting kind of in that tool. That's how I use it for myself. But my day in and day out, again, just depends kind of on my schedule. I usually naturally am in like an 18-hour kind of fasting, just that's naturally what I fall into. Some days it's 20, some
Mhm.
days it is 24. It just depends what's going on. But I think just again, getting into your normal pattern, what works for you, um, is is what's important. And I did want to touch on pregnancy because we're not extended fasting during pregnancy. But I do tell my pregnant patients to try to also stop eating by 8 p.m. Because just because you're pregnant, there is no need for you to eat at all hours of the night. Like
Mhm.
there really isn't. And so,
You mean like my Sonic 9 p.m. half price milkshakes were a no go? Where were
and
you
I
at 10 years ago?
it's just it's one of those things where, and again, we all have our occasions where we may have something. So I don't, purport to be perfect at
Yeah,
all. But
nobody's perfect.
I think the problem is we've endorsed this thought process for too long. Like you're pregnant, so eat for two, it's fine, this, that, or the other. We need to kind of rephrase or like shift our mind. The eating for two is because you are eating to properly give your baby the building blocks for the rest of their life. That is what eating for two is. It is
Mhm.
not having extra portions of things just because you're pregnant.
Yeah, I think that's the thing to highlight, even in and out of pregnancy, is that intermittent fasting is a great tool, but you want to make sure that when you're feasting, you're getting appropriate nutrition. And if your goal, which my audience knows I love muscle, if your goal is to gain muscle, like you need to be getting adequate protein, and that might not be with one meal a day. You might need a larger eating window. Just put everything in context of like what outcome are you looking for,
Yes.
and what tools are going to be good tools to use to get there.
Well, and I think that is important too, because I run into so many people who are like you look at their nutrition and their nutrition is amazing and they're disappointed that they can't fast longer. And I'm like, that's fine. Like, you don't need to fast longer. I'm like, your hemoglobin A1C is now normalized, right? You're building muscle the way you want to, right? You feel great. You're not anxious anymore. You're sleeping well. You're happy. Why are you focused on that? Your friend fasts for 20 hours and you fast for 16. Who cares? Like,
Yeah.
it's working for you.
Yep. Yep. Totally. Be your own expert. Be
Mhm.
your own expert. I love it. Okay. So I end all my podcasts with something called the semen analysis. And I pulled a study that just came out last year. Actually, one of my colleagues sent it to me. So it's January 2nd, 2020. It was published in the JAMA, Journal of American Medicine. So it's called Occupational Reproductive Hazards for Female Surgeons in the Operating Room. And we know, discussing with a lot of my reproductive endocrinology partners, that surgeons, female physicians in general, have higher rates of infertility. And some of it is the delayed childbearing due to training and residency and finding a partner and things like that. But this study specifically was looking at the hazards that surgeons get exposed to in the operating room. It highlighted that these surgeons have increased rates of infertility, pregnancy complications affecting both the mom and the fetus, higher rates of spontaneous abortion, preterm delivery, growth restriction, and congenital anomalies. They did note that a lot of it was because of older age, but they said the working demand and conditions, the hours that we work, the hazards like radiation, surgical smoke, working conditions, sharps injuries, anesthetic gases, and intraoperative use of toxic agents, all were basically at play here. And so, is this something you look at when you see pregnant patients? Like, do you talk about occupational hazards or what other things in their life they could be exposed to? I think in the world of like chemicals and phthalates and endocrine disruptors, sometimes we don't think about that.
Yeah, no. So we take a health history for people where it goes over kind of like, do you perceive your environment is safe? Are there any exposures that you're concerned about? What do you do? And so then when we ask occupation, then we go into more like, well, what is that? For instance, if you are working in a chemical lab, right? Like, and you're trying to get pregnant, do you know like which chemicals that you interact with on a day-to-day basis? Which ones don't you do? Are there ones that you can kind of push off to the side and have someone else handle? And even if that's the case, what about the fumes? So we do look at exposures and things like that. The scary thing is that I think there's so much that we're learning as we go or not realizing. Do you know what I mean? Like things that we wouldn't even think are hazardous might be hazardous, right? Everyone thinks about like lead paint and things like that. But what's in our water? Do you know what I mean?
Yeah.
What are kind of and I think have so many exposures today prior to even probably 20 or 30 years ago that we're just learning about. Or maybe they're not no exposure and just no one cared to look at them until recently. I don't know,
Yeah.
which it is.
Yeah. I mean, I think it's crazy because, they've looked at cord blood studies, like the number of chemicals that are found in cord blood. Like it's just
Crazy.
it's the industrialized society. Like it's just things that we don't think about. And I'm sure is going to have a long-term impact. I just saw an email alert this morning. 1 in 44 children now are diagnosed with autism.
Mhm.
It's like there's something, and I just, as an obstetrician, these things matter. And I always tell patients, like, listen, like, go through your cabinets, go through your kitchen. Your skin is your second largest organ. Muscle should be number one. That's why you got to lift weights. Um, but it absorbs a lot of things. And so, just
Yes.
think about everything you put on your skin, you touch, you're exposed to. And as this study highlighted for female surgeons, there's other occupational risks too. So
Well, and you make a point too. I mean, even, and I know not everyone has access to grass fed or grass finished, beef or produce or things like that. But I also think it highlights the importance when we look at where our food comes from. If you are fortunate enough to be able to buy locally sourced, look for things like that. Visit the farm if you can. I mean, again, I'm spoiled. I'm in Kansas. We buy a whole cow every year from a
yeah,
grass finished, grass, fed farm. I visited the farms. I've seen how they treat the cows. You know what I mean? I know where I get my chickens from.
less
Uh,
people that touch and process your food, the better.
yes, and again, I know that that's not possible for everyone, but even if we start to think about it, do you know
Mhm.
what I mean? And just again, like you said, thinking about what you put on your skin, what's in your cosmetic products, what's in your toothpaste, I mean, there's so many things I think we just don't, even consider it. And I think all of these things are on that journey to maximizing our health.
Totally. Well, thank you so much, doctor, for your time and your expertise. I know people are going to get a ton out of this conversation. Tell people where they can find you and how they can work with you.
Yeah, so you can find me on social media, and it just depends on what you're interested in. If you're interested in learning more about intermittent fasting via social media, then I would say check out The Fasting Doctor, whether that's on Instagram or Facebook, or my website, thefastingdoctor.com. If you're interested more in pregnancy and health and wellness as it pertains to pregnancy, then visit caseyperinatal.com, or on Instagram, it's also Casey Perinatal Specialist of Kansas City.
Awesome. Awesome. Well, thank you. Thank you, everybody, for listening to this episode. Make sure you download it. Give us your likes, your dislikes, your comments. Give us your feedback. We appreciate all of it. And thank you again. Everybody, have a great day.